Hi everyone. Today I will talk about the malaria, a potentially fatal disease caused by a unicellular parasite, the Plasmodium. So malaria caused by parasite and the vector of the malaria is the Anopheles mosquito. The female Anopheles mosquito is the vector for the malaria. The species Anopheles female Stephensii is responsible for the urban malaria. So malaria is potentially fatal disease caused by bite of the female Anopheles, but it bites both male and female and can cause malaria in both male and female. So malaria is potentially life-threatening disease, especially the falciparum malaria is life-threatening or fatal disease in untreated cases. The etiology of the malaria. Etiology The malaria is especially a disease of tropical and subtropical and temperate zones of the world, especially the Central and Latin America, the Central Africa, the Southeast Asia, the Indian subcontinent and the Middle East, the Europe and the countries of North America are malaria-free zones, but there are cases of malaria in USA, Canada and Europe and people which have traveled recently or remotely in the malaria endemic zones like the Southeast Asia, Africa and Indian subcontinent and the Middle East. So malaria is caused by parasite, the Plasmodium. There are 5 species causing the malaria in human beings. The 4 species of Plasmodium are very common. The P. vivax, P. oval, Plasmodium falciparum and Plasmodium malaria. The vivax and falciparum are most commonly occurring types of the malaria. The oval is less common and the Plasmodium malaria is a very rare type of malaria. One more type of malaria, also known as monkey malaria, and especially occurring in the Southeast Asia in the long tails and big tails, macaque monkeys. macaque monkeys. There are some pigtails and long tails macaque monkeys, maca types of monkeys, also having same illness like malaria, and this type of malaria is caused by Plasmodium knowlesi. This is a very rare type of malaria caused by the Plasmodium knowlesi, and especially in Southeast Asia. This type of malaria is seen in Southeast Asia only and caused by the knowlesi, and this is also a very fatal type of malaria, but not as fatal as it is seen in Plasmodium falciparum. The clinical presentation of the malaria. After the bite of the mosquito, the patient is having some history of bite of mosquito. Especially the female Anopheles or female Anopheline mosquito are causing the malaria. So female Anopheles mosquito is causing the malaria. When this mosquito takes its meal from bite of human blood, this mosquito injects the sporozoites in the capillaries of the human skin. So by bite of mosquito, this is the liver and here it is spleen. So when the female Anopheline mosquito bites the human being to take its nutrition or meal, this mosquito inject the sporozoites in the capillaries of the human being. Within minutes, these sporozoites enter in the human liver. These sporozoites, which are injected by the bite of female Anopheles mosquito, are taken by the liver within minutes of bites. These sporozoites are taken by the hepatocytes. Initially, these sporozoites are in the liver parenchyma and in the capillaries and sinusoids of the liver, but these are engulfed or taken by the hepatocytes. These sporocytes enter in a asexual cycle of the Plasmodium. So this is asexual cycle or the non-sexual cycle of the Plasmodium. As the time passes by, one sporozoite, by the process of asexual reproduction, forms 12,000 up to 30,000 merozoites. Listen again. Female Anopheles mosquito feeds the human blood for its nutrition. At the time of feeding, this mosquito injects the sporozoites which are present in the salivary glands of the female Anopheles mosquito. After injecting, these sporozoites enter in the capillaries of the person and in the blood circulation. These sporozoites enter in the liver. In the liver, these are taken by the hepatocytes and these sporozoites enter in a reproductive cycle, that is asexual cycle of reproduction of the Plasmodium. A single sporozoid divide and form up to 30,000 merozoites. These merozoites enter in the RBCs or the erythrocytes. This cycle is known as pre-erythrocytic cycle. So this is the pre-erythrocytic cycle. After forming the merozoites, these merozoites invade the RBCs or enter in the erythrocytic cycle. The RBCs are having the receptor for the malarial parasite. These are known as Duffy blood group receptors and known as FYA, A and FYB. These are Duffy receptors. The persons who are not having Duffy blood group or the patients who are negative for the Duffy group are resistant to the development of vivax malaria. So the people who are living in West Africa are not having Duffy blood group receptors FYA and FYB. These persons are resistant to the development of the Plasmodium vivax malaria. Some blood groups like the blood group C blood group F, and some heterotrophic blood groups are resistant to the falciparum malaria. The newborns up to age of 4 to 6 months are also having the resistance against the development of the malaria, and persons who are severely malnourished are also having low chances of development of malaria due to lack of nutrition for the Plasmodium parasite. So this cycle is the hepatic cycle or pre-erythrocytic cycle. After pre-erythrocytic cycle, the merozoites enter in the RBCs by attaching the FYA and FYB receptors on the RBC. The merozoites are taken by the RBC, where initially there is a ring stage, then there is a trophozoid stage, and then schizones are formed. These schizones use the 2/3 hemoglobin of the RBC as its nutrition. So the infected RBC is having schizones. This schizone uses 2/3 of the hemoglobin of the infected RBC, and after 48 to 72 hours, this is the erythrocytic stage. So this is erythrocytic stage, and it is having a period of 48 to 72 hours according to the species of the Plasmodium. So initially there is a ring shape, ring stage, then trophozoid, then schizone. The schizone takes 2/3 of the hemoglobin of the infected RBC, and then this RBC ruptures. This rupture of RBC will release 8 to 12 or more merozoites. This rupture of RBC and release of these merozoites from the RBC is the main pathophysiology of the malaria. The release of the merozoites in blood and the toxins which are produced by merozoites, and the production of cytokines by release of merozoites is the cause of fever in malaria. So these merozoites are responsible for the fever by release of the cytokines. So Plasmodium vivax, falciparum and oval are having 48 hours of the cycle in RBCs. So vivax, falciparum and the Plasmodium oval are having 48 hours period of erythrocytic stage. So we can see the paroxysm of fever periodic paroxysm of fever at interval of 48 hours in vivax, falciparum and oval. In vivax and oval, it is known as benign tertian malaria. So in vivax and oval, it leads to benign tertian malaria, but in case of falciparum, the erythrocytic period is also 48 hours, but here we can't see the typical periodic paroxysm of the fever. It is aperiodic, or we can see the multiple spikes of fever in a single day, and this type of fever is known as malignant tertian malaria. Malignant tertian malaria. In case of the Plasmodium malariae, the erythrocytic stage takes 72 hours and it will cause the P. malariae. It is the quartan fever. The paroxysm of periodic fever occurring in interval of 72 hours. So the vivax and oval are causing the benign tertian malaria, and the falciparum is causing malignant tertian malaria fever. But in case of malaria, it is the quartan type of fever. One more interesting thing in the vivax and oval. Here we have seen the development of merozoites. In the pre-erythrocytic or hepatic cycle. In case of vivax and in case of malaria oval, both types of malarial parasites are having a different type of cycle. This cycle is known as exoerythrocytic cycle. This is known as exoerythrocytic cycle, where a different cycle is taking place in the hepatocytes, the merozoites, which entered in the RBCs. But there are some merozoites which re-enter in the hepatocytes. So there is re-entrance of the merozoites in the hepatocytes. This exoerythrocytic cycle will form some merozoites which enter and re-enter in the hepatocytes and maintain the asexual cycle of the Plasmodium in the infected human. When this malaria patient is treated, all the merozoites which are inside the erythrocytes and inside the blood are killed by almost all anti-malarial drugs. but this exoerythrocytic merozoites are not killed by these anti-malarials, and this stage or this cycle is responsible for the relapses of the malaria. So this is responsible for the relapses of the malaria, and this type of the cycle is eradicated by the radical treatment. Radical treatment. Some merozoites are entering in a separate type of cycle and are not dividing to form the merozoites, and these will form the gametocytes. So gametocytes are formed in the blood. Two types of gametocytes are seen in Plasmodium: microgametes and the macrogametes. In the GIT of the mosquito, Anopheles female mosquito, when this mosquito bites the infected person, the mosquito will ingest the micro and macrogametes. In the alimentary canal or GIT of the mosquito, these micro and macrogamete will unite to form the oocyst inside the mosquito. These both will unite to form the oocyst, and this oocyst is having the micro and macrogamete union, and this oocyst will burst to form the 8 to 20 sporozoites. These sporozoites are transferred to the salivary glands of the mosquito, and when this mosquito bites the human being, these sporozoites will re-enter in the blood of the human being, and this cycle of the asexual cycle inside the human being and the sexual side in the mosquito is maintained. So this was about the Plasmodium vivax-like cycle. So patient of malaria may present as a severe headache. Virtually all patients of the malaria are having mild or severe headache. The paroxysm of periodic fever with shaking, chills and rigor. So I was talking about the clinical presentation of the malaria. So patient clinical presentation. Headache. Virtually all patients of malaria, all patients of malaria are having headache, fever, high grade fever, about 40 degrees centigrade. The history of shaking chills. History of rigor. The patient of malaria is having a history of the headache, virtually all patients, fever, shaking chills, rigor. These are best seen in vivax type of malaria. The shaking chills and rigors are best seen in the vivax malaria. The myalgia, arthralgia, the patients are also having the anorexia and vomiting. Less commonly seen the jaundice, the anemia, especially seen in children, the cerebral malaria, the renal failure, severe anemia and pulmonary edema are especially seen in the Plasmodium falciparum type of malaria, but commonly virtually all patients of malaria may present as headache, maybe mild or severe, fever, high-grade fever up to 40 degrees centigrade, shaking chills and rigors best seen in vivax and sometimes in oval also. The myalgia, arthralgia, joint pain, muscle pain, anorexia, lack of hunger, and vomiting, jaundice, and anemia are less frequently seen in the patients of the malaria. So history taking makes an important part of the diagnosis of the malaria, the bite of the mosquito in malaria endemic zone and the recent or remote traveling to the malaria endemic zone. The patient is, the human is bite by the Anopheles, and after bite, after several weeks, the patient develops the signs and symptoms of the malaria. This phase or this period is called as the incubation period. So there are 8 to 25 days incubation period is seen in the oval, vivax and the falciparum. In case of novelaceae, it may be less than 12 days. This novelaceae mimics the parasite of Plasmodium malaria,